This episode of Pupil Pod is supported by Dompe.
Welcome to the Pupil Pod, where we use clinical cases to guide discussions on board review topics. I'm your host, Sila Bal, and my guest today is Dr. Morgan Micheletti. Dr. Micheletti is a cataract, refractive, and complex anterior segment surgeon out of Texas and posts amazing surgical videos on Instagram, which I personally love watching. Dr. Micheletti, thank you again for joining me tonight.
Hey, it's my pleasure. Happy to be here.
So let's get right into the case. You have a 65-year-old woman with a history of high myopia and radial keratotomy who comes into your office for evaluation of cataract surgery. During your technician's initial workup, she notes that the patient has a best corrected visual acuity of 20/50 with a BAT of 22/50. Her axial length is 29, and her exam is notable for pseudoexfoliation material, a poorly dilated pupil, which is less than 5 millimeters, and a 3+ nuclear sclerotic cataract. Now, I know this isn't our typical bread and butter cataract patient, but as we all know, these eyes are pretty common, not just in training, but beyond. So I think that this is the perfect patient to lead our discussion on complex cataract cases. So let's start here with her history of refractive surgery. How do you manage IOL calcs and preoperative testing for patients with previous refractive surgery? And what surgical considerations do you have for patients like this one?
Great question and a very challenging case. Yeah, that's a very good case. So obviously this 65-year-old woman clearly sounds like she has a visually significant cataract. And so now we're looking at, all right, what do we need to do about this? And like you brought up, IOL calculations in these post-refractive patients is a very important topic, something that kind of guides the outcomes, obviously. So just getting into some of what we see with RK, we had the PERC study that showed there were about 60% of patients had these diurnal fluctuations, many with hyperopic shifts, and that the cornea steepens as the day goes on. And that's kind of your classic board question. You get this nocturnal flattening, presumably secondary to the incisional edema that causes some flattening. And then as they wake up and the cornea dries out, it steepens and you can get these large fluctuations. And those fluctuations are very dependent on the number of cuts. So if you have something that's 8 cut, if you have an 8-cut cornea to a 4-cut cornea, you may not get as many fluctuations if you have a 16 cut. I've seen up to 30 cuts. I mean, I've seen some pretty gnarly things. And then you get patients that get T cuts. You have things that are going all the way from the central 1 millimeter zone all the way out to the limbus ones that are just kind of in a medium type zone. And so the fluctuations are very dependent on the surgery that was initially performed. But it's hard to really measure this. We can't really ask patients to come in first thing in the morning and last thing in the afternoon and get a, what's the difference and try to target that middle vision. That middle kind of the road of the sinusoidal curve and their refraction, it's unrealistic. So we do rely on calculations, and nowadays we're pretty lucky. I mean, we really do have great formulas. So for me personally, I'm using a lot of just Barrett 2 and what Veracity and IOL Master 700 or your Argos, other biometers have, and checking that box on just post-refractive typically is enough to get you pretty darn close. And in terms of other values to use, your central Ks your central keratometry in a post RK patient is not thinned or changed, unlike your post LASIK patients. So most of the time, those are actually pretty reliable measurements, especially in the central 1 to 2 millimeters, and multiple devices can give you that reading, such as Pinacam, for example. So using various devices, plugging those all into a formula that can, I personally like to use kind of some integrated Ks using my Veracity to kind of spit out a well-rounded number that I truly trust in order to use moving forward with my calculations. And I think that it's become less of an issue than what it was probably even 10, 15 years ago in terms of predicting with relatively good accuracy ELP in these patients. So there are some special considerations the first thing is expectations. Anytime you're talking about IOL calculations, and this is a discussion with the patient from the onset, is these are challenging cases, right? I mean, these are very challenging cases. These patients previously sought refractive surgery, and so they're looking for the best possible outcome they can get. It's what led them to get RK in the first place. And so setting realistic expectations and goals and what their outcome may be and the fluctuations that they will continue to experience is very important from the onset. A lot of these patients have dry eye or other ocular surface disease that need to be managed. And then really discussing separately, and this is getting a little further on into the discussion, but it's important from the onset, is recovery time. A lot of these patients postoperatively can have corneal fluctuations that are worse and more significant over the next 2 to 4 months even. So it's really important to let them know that it's going to take some time for them to become more stable. So another thing to think about is IOL choice. And so once you have your calculations, choosing the correct IOL can be a challenge in these patients because you want to find something that has the best potential of giving them a good refractive outcome. What's recommended many times is an aspheric IOL with negative SA, but it's not always going to be that helpful. A lot of these patients have very high spherical aberration, and bringing down their spherical aberration by 0.17 or 0.26, a lot of what these negative SA lenses are, it's probably not going to make that big of a difference versus say, zero aberration IOL or one with no spherical aberration correction. So moving on, as we start thinking about these patients, one of the important things, and as you're sitting there in your evaluation, is figuring out, where am I going to enter the eye? And sometimes it's very easy, sometimes it's very hard. So in a 4A cut patient, it's very simple, right? You're going to enter in between the wounds as close to the temporal limbus as you can. That's where I prefer to enter. But sometimes it gets harder as you get 12 cut or 16 cut. Occasionally, if it doesn't go all the way out to the limbus, you can squeeze in. It depends on your wound size, but you can squeeze in a 2-4 sometimes in 12 cut if they're not perfectly symmetric. But many times we're turning to scleral tunnels, especially if we're talking about using a larger diameter IOL, especially if we're talking about a lens that requires a larger incision. For example, the light adjustable lens needs about a 2.8 millimeter incision, and the IC8 or the aphthera needs actually a 3.2 millimeter incision. And there's some other reasons why that is for the aphthera in particular, but that's probably something for another day.
Okay, well, that definitely gives us a really great foundation for what we need to think about in post-refractive patients. But can you tell us a little bit about some of the things that you go through with patients that have pseudoexfoliation syndrome?
Absolutely. First thing you want to look at is any sort of zonular instability. So I'm taking a look, seeing if there's any phacodenesis visible to the slit lamp, and you don't always see it. I mean, there are times that it may look rock solid on slit lamp exam. You have them move their, look side to side, and things look really stable. But intraoperatively, as soon as you put some visco to your dispersive OVD of choice in, that chamber deepens, and you can tell that there's some zonular issues. So I think doing your best to assess that can give you a little bit of a heads up on how early you may need to use something like a CTR in the case of zonular instability. If I think something's really unstable just from the get-go, I'm going to be looking to put in some sort of tension device in earlier rather than later in the case if it's more of a prophylaxis or just something to give me to suture to later. A lot of these patients are prone to capsular contraction. There's some data that shows 3-piece IOLs can help when they're placed in the bag. But I think it depends on age and other factors. Again, in this case, it's a 65-year-old female. So we have to imagine this lens needs to stay in place for 35 years. I like to think all my patients live to 100. But if this patient were 85, maybe that's not quite so important because the chance of that happening in their lifetime is a little lower, just on average. So regarding intraoperatively, you can change to low flow or lower your bottle height or lower your IOP, which is what I do sometimes. Is I'll lower the IOP on my phaco machine just to try to reduce that initial posterior push that you can sometimes get as you first go in and kick on irrigation. Another important concept is creating a rhexis in these patients. It can be very challenging, especially if in a lot of these pseudoex patients, they don't dilate very well. So you can't always depend on femto. So you have to think about how you can create a rhexis with which you're going to, a lot of times, if they do have some zonular instability, you'll start seeing those folds in front of the flap, in front of your capsular flap as you're creating your tear, which indicate zonular instability and can increase your risk of a tear out, things like that. And so it's really important to maintain anterior chamber pressure using your OVD of choice while you're creating a rhexis in these cases. There are some other options like precision pulse capsulotomy. I would use those in caution in patients who have zonular instability, just because it does take suction on the capsule. And while you can get away with it in small pupil cases, which is where I really like to use it, it does put some added stress as it puts added stress on the anterior capsule if there's pre-existing zonular weakness. If there's not, it doesn't, because everything's equally distributed. But in cases with zonular weakness, I have seen it kind of pull the bag a little more into the suction ring. So I would just use caution. Not to say that you can't do it, but just use caution with those. Then moving on in terms of nuclear disassembly, you want to do something that's very neutral on the zonule. So for me, on most cases, I'm horizontal chopping anyways, but I think especially in these patients, horizontal chop's a great option. You're not putting any posterior pressure like you could with a vertical chop, even though it's relatively atraumatic. And a lot of times, even with sculpting, you're putting some posterior pressure on if you're doing a more old school divide and conquer. So the other option is, or one other thought for nuclear disassembly in some cases like this, which can be neutral on the zonules, is a MyLoop. But that's another thing where you have to use caution. While it can be zonular friendly, you have to be really careful as you pull that ripcord, because as you do, it can start pulling pieces with it that can get entrapped under the anterior leaflet. And so then you have basically your hand, MyLoop, all connected to a couple fragments that are inside of a bag that you're then pulling. And so that can lead to some more zonular instability as well. So if you can do a well-controlled MyLoop in the bag with all those forces moving centripetally, then that can be very beneficial. But you have to make sure that you're not putting undue stress on the anterior leaflets and pulling everything forward, as that can kind of go against what you're trying to do. A lot of times in these cases, I'm looking at when am I going to put a CTR in, because I do like to put them in. And most patients who have very obvious pseudoexfoliation, I'm already thinking, all right, what point am I going to put them in? Many times, I just put in at the end of the case. I go with my lens of choice, whether it's a toric or something else. Now, obviously, we may not be talking about that in this particular case, but just in general with pseudofakes, just in general with pseudoexfoliated patients, I'm still open to put in any lens in for the most part, but I'm going to plan to use a CTR because it improves capsular stability long term, and it gives me something extra to suture to should it become dislocated in the future. So in this case, if she has zonular instability that I notice early, I am thinking about putting a CTR in relatively sooner rather than later. Now, there's different types of CTRs and there's different sizes available. So, there's two different ones that are FDA approved, the Mortier and the Alcon version, and most of them come in similar sizes, and the indications are pretty similar. So for patients who have an axial length smaller than 24 millimeters, you want to put in a type 14, which is a 12.3 millimeter diameter, and compress it down to about 10 millimeters. For those patients with an axial length between 24 and 28 millimeters, you're looking at a type 14C or the 13 millimeter diameter, and that compresses down to 11 millimeters. Now, I will say, I for the most part will go with the type 14C unless it's a really small eye. Bigger is better. When in doubt, I think it's very reasonable to go big. And axial length for me is the main determining factor on which size I use. Now, there is a larger size, the 14A, for axial length greater than 28. So in this particular patient with an axial length of 29, this may be where I would make sure I have that size CTR in the OR with me. Although I can say that I don't think I've ever put in a type 14A. That's a very large CTR. And there's a couple different types. The kind that I like is the preloaded one. It's just so much simpler, and you don't have to worry. In terms of efficiency, it's just so much easier. You basically push on it and retract it, and then you're in the eye. Now, delivering these things is a different story. So again, it all comes down to where you're actually implanting it in the case. If you pop open the rhexis and you're going to put it in right away, you're going to do it a little differently than you would if it were at the very end of the case. So a lot of times if I get the lens out and everything looks great, I'll go ahead and put the IOL in, and then I'll put the CTR in. And what I'll do is I'll use a Sinskey in my offhand, which I'll grab that leading eyelet with, And it's a very atraumatic way to insert the CTR. And it's a way to ensure that it's going where it's supposed to. Now, early on, if you just open up your capsule, that's where you may just implant it like you normally would. You're just going to slide it in. It's going to kind of snake all the way around. And that's perfectly fine. You will probably trap some cortex. And so there have been some other things that you can use, like the Henderson ring, which has these little serrated edges to help or improve your cortex removal. I will say that I haven't had too much of an issue removing cortex in these patients that I put a CTR in early. It's a little more cumbersome, but it's really not too bad. It's really not. There's also modified CTRs like the Sioni ring that have these little eyelets similar to like a CTS. It's like a CTS CTR combo, and that allows you to suture fixate the entire ring to the scleral wall. I prefer to use 6.0 to 9.0 polypropylene for these things, but plenty of people use Gore-Tex if you're going to suture fixate. And the indications for that would be really some sort of zoniopathy greater than 4 clock hours or so. I think a lot of times you can get away with the CTR as long as it's 4 clock hours or less. But if it's more than that, you're probably looking to suture. I actually like to do a CTR, then a CTS. And if I'm going to suture fixate, it just gives me a little more flexibility because I can independently place them. So I can get the CTR in the bag. I know exactly where my zonulopathy is, and that's where I can go ahead and put that CTS in and suture fixate it exactly where I want to. And I can also hold on to it with capsular retractors. So for me, that's how I like to go about it. But there's plenty of great videos out there that show doing it with multiple different ways.
This episode of Pupil Pod is supported by Dompe.
Do you ever use hooks?
You can. I use hooks. Typically, I'll use an iris hook to hold a CTS. I think that provides a little more stability. I think the capsular hooks are relatively cumbersome, and I'd really like to minimize, especially in an RK patient or someone it's just a lot of incisions that you're already making, So I try to minimize the amount of incisions through a cornea that's already been pretty beat up with RK and things like that. So in general, I don't use a ton of hooks, although I do use them from time to time.
I've actually never seen anyone using capsular hooks yet. Knock on wood.
They're big. I mean, they're relatively big and kind of cumbersome. They really are. Their angle has to be very different. When you're going down to grab a capsule with capsular hooks, it's a very different angle than when you're going in to grab an iris with iris hooks.
Yeah.
So it's also something that you have to really kind of plan ahead and just your angle of insertion in terms of making your entry into the eye.
Okay, so continuing on our patient with their multiple issues, this patient also had poor dilation, likely secondary to her PXF. What are some of the techniques that you use in patients with poor dilation? I know we already started alluding to iris hooks, but any others that you use that you like?
Yeah, the main thing I use is really the X1 Expand from a company called Diamatrix, which is actually local to me, which is kind of cool. But I really like it. It's a nitinol ring similar to a MyLoop. It holds the iris open in a very atraumatic fashion, and you can actually grab the capsule and connect it to the iris, essentially using the X-Band. In fact, I think the video of the year for 2018 for ASCRS was, I think Alan Crandall showed a case of this where he kind of grabbed both the bag and the iris in order to support it while he was doing the surgery. So it's been done, and it's a really cool way to do it. I've only used it that way once. I typically like to support them independently. I just think it gives me a little more flexibility. But obviously, most of us have all used Malyugins, and they're great. I think there is nothing wrong with the Malyugin or what are some of the other ones? There's like an eye ring. I think Dr. Canabrava has his new pupillary expansion device. So there are so many options for pupil expansion that you really just have to find what fits your comfort and what you feel in your hands causes the least amount of trauma to the iris, because that's really what when I look at what I'm going to use to dilate a pupil, I want something that's going to be the least traumatic in terms of insertion and the least traumatic in terms of what it's going to leave behind. And so sometimes with certain things, you can see some trailing pigment and all this stuff. And it just, you're like, oh, that I don't want to see that. Now, I think there are some drug options as well. I think Omidria can be great. I have used it quite a bit and have had good luck with that. And then your whatever preoperative regimen you find works for you, whether it's, some atropine or if you're going to use some sugarcane in the eye or intracameral epinephrine, all of these things can be great surrogates as well, because you want to try to get that pupil as open and stable as you can before needing to expand something else. Now, for me personally, it has to be a pretty small pupil for me to put in a ring. I'm pretty comfortable operating through a 3 millimeter pupil. It takes a little longer sometimes, but if it's an extra minute or two, then it's not too bad.
An extra minute or two. How do you make now I'm intrigued. Now I'm like, wait,
Yeah,
how? I
sure.
want to do that. How do you make your 5.5 millimeter rhexis through a 3 mil pupil?
Yeah, so there's a couple different ways you can do it. Now, in this case, it's a little more challenging because they have pseudoexfoliation and zonulopathy. But a lot of times, a great option in these small pupil cases is to use a precision pulse capsulotomy, because you can just put it right in. So this is Zepto. You can just slide it right into that pupil, right under that pupil. You don't have to worry about the iris. You center it on the Purkinje reflex, and bam, you're done. You've got a great centered rhexis, and you come out and you carry on with your case. You can get some viscodilation. And so if I can viscodilate, because a lot of times that's when you're going to get your best dilation, is while you're doing your rhexis. And if I can get at least, what I should have said is, it is challenging to do a 3 millimeter pupil with a rhexis and a 3 millimeter pupil. But a lot of times they come down to 3 millimeters when you go to do your phaco, right? So if you can get at least 4 millimeters, and you can use a second instrument through a side port to kind of push the iris out of the way, whether it's a Kugelin or um, some sort of chopper that has something in order to do that, such as the chopper I designed, for example. But that you can kind of trace that. And so you kind of, just like you would do a torque in these cases, right? So you've seen pupils come down to 3 millimeters, and you still got to go out and check your torque marks. So same thing, you can use a Kugelin or something else. And you've done a rhexis thousands of times, right? I mean, so you know where you are. You don't always have to, I mean, yes, you want to be able to know where your rhexis is, but at a certain point, you do have a feel for where you are. Now, in this case, I would exercise extreme caution trying to do this with minimal visualization in a patient who has some zonulopathy or pseudoexfoliation.
Maybe, yeah.
Yeah. This probably isn't the best case for that. So, no, in a patient like this, if they weren't ideally dilated, especially in a complex case like this, this is probably one of those examples where I definitely would use some sort of hardware to dilate the pupil. I have, I've never regretted ever using Trypan or ever using some sort of pupil expansion device. I've regretted not using them, right? So I always err on the side of caution. You don't have to try to be a hero, with a small pupil, but it is possible to do. And I think that there are certain patients where it can make sense to do, but yes, obviously always do what is the most comfortable for you.
That's certainly the mantra that we're taught in training too, is like, I've never regretted using Trypan, but I have regretted not using it. So
Exactly.
it's a good mantra.
Yep.
So switching gears a little bit to our next problem, which is the high myopia, high axial length. What are some of the pre, intra, and post-operative considerations for patients like this with a high axial length, such as this patient?
Yeah, so I think an important thing is to just check for a PVD. I think that's a nice, easy thing to do for most anterior segment surgeons. I in a patient with a 29 millimeter axial length, I'm still probably having one of my retina partners take a look at this patient beforehand, just to make sure, especially before cataract surgery at 65. For someone who's a lower myop, I'm not quite as worried, but 29 millimeter axial length, I'd really like them to take a good look at the aura if they, in the surrounding area. Next, really lens calculations, right? So we already talked about this. This is a patient with RK. Now she's an RK patient with a very long axial length. So just making sure, and again, most of our current generation IOL formulas do really well with this patient, even as they are without any sort of modifications. One thing that is really nice in these patients is a lens like an LAL. And that's because you can get close with your calculations. You don't have to fret about, okay, I may be a quarter of a diopter or half a diopter or even a diopter off, because you know that you can fix it. You can fix it in post, as they say, right? But the issue is it only goes down to a 10 diopter. So if this is a 29 millimeter axial length eye, even if the Ks are relatively flat, you're still probably looking around a 10 diopter lens. So it just depends on whether that'd be an appropriate lens for the patient. And you could also think, well, maybe I'd go down the path of like an IC8 or the Apthera, right? The new lens that was just FDA approved from AcuFocus. So the lens I like to use in general in patients who are super high myopes is the AR40 or the AR40E and M. Is just whether it's a meniscus lens or not. It's a great 3-piece lens. It gives you lots of options, especially in these patients. So, in this particular patient, if they weren't a candidate for an LAL or maybe like the IC8, just because I know that both those lenses are going to really help this patient in general, both with the fluctuations and giving them time to recover before we do any treatments with the LAL, to just taking advantage of the pinhole optics with the Apthera. But in general, I think an AR40 is a good option here if it's something like a 5 diopter or even a -5 diopter lens, and that just depends. Now, in surgery, so intraoperatively, one thing that we see quite frequently, it does happen, and sometimes it takes you by surprise, is lens iris diaphragm retropulsion syndrome. And so essentially, you see it a lot of times when you first go in with your phaco and kick on continuous, and the chamber just goes whoosh and deepens. The patient takes a deep breath because they're feeling the sudden burst of pressure. And the important thing is to, before you enter an eye in any of these patients, have that second instrument ready to go in the eye. And sometimes you can try to go in, like as soon as the right hand's in, or whatever your phaco hand is, go ahead and get under there and just start aiming to get under the iris, just to try to prevent that. Because the other thing, if it happens in a patient who doesn't have zonulopathy, it's painful and it's not ideal, but it is unlikely to cause some other issues. In a patient with zonulopathy, that can bust a few more zonules and leave you with some more issues during the rest of the phacos. So trying to prevent that from the onset. So, going in the eye, making sure that you have a good fill with OVD, and then going in the eye and slowly, you can this is where you can turn down your irrigation or your IOP and slowly kind of moving into that mode just to try to minimize that. So going in, and that's another option too. So you can, some people will say, oh, go in dry, have your second instrument ready to go right under the iris, or even just go ahead and lift up the iris a little bit. Those are all some things you can try. Now, in terms of RD risk in these patients, some people will say avoid silicone lenses in these patients. I don't feel that strongly about that. Most patients, if you think about these patients' RD risk, even in a 29 millimeter eye, if they've had a PVD, it's probably 1%. And then of the patients who need silicone oil, a lot of times that's redetachments or PVR cases, things like that. It may be 1% of that 10%. So 1 in 1,000, give or take. So I wouldn't exclude an LAL patient just because they're a high myope, just because they may one day need silicone oil. Because we've all gotten so good at IOL exchanges and doing Yamanis and other, sutured IOLs, that I think that the IOL choice would be the least of the patient's problem if they needed silicone oil. Most of the time, you're not getting that. You're not going to get that same visual outcome that you were expecting with that kind of a lens in the first place.
Right.
But yes, typically the only silicone IOL I would use in a patient like this would probably be the LAL. So unless they're a good candidate for that, I don't think it's too big of a concern.
Do you ever use AC maintainers in these high myopes, or change your flow settings, or not really?
Not really. I mean, I've seen people do it with an AC maintainer. I think it's a reasonable thing to do. I personally don't. I mean, I just kind of watch out for that retropulsion syndrome. But, for the most part, as long as you can avoid that from the onset, you're good. And once that lens out, you really don't have to worry about that too much anymore, unless, sometimes you can get it if you can get the same thing even when the IOL is in and you go back in and the iris can, deepen the whole chamber and everything else. But for the most part, once you get through that initial time you kick on irrigation inside the eye, then for the most part, you're in good stead. So,
Final moment here. Could you summarize kind of what your plan would be for this complex cataract patient with the history of high myopia and an axial length of 29, with the pseudoexfoliation and zonular weakness, the poor dilation, and the history of radial keratectomy?
So in this patient with less than 8 incisions, it's really easy to make an incision on the side, and so you could probably get in even up to easily a 1/8, something big enough to do an LAL without a scleral tunnel. And I think that that's a reasonable lens if it fits the patient. So if it's 10 or higher that they require, I think that's a reasonable option. Again, it's a 3-piece lens, so you always could pull it out of the bag if there was an issue and Yamani it, or refixate it using other methods. It just gives you a lot more in the way of options. I think if they weren't a candidate for the lens, let's say they were they require like a plano lens or a -1. I think the AR40E is a great option. Again, it's a 3-piece lens, and I think a 3-piece is a very reasonable option for this patient. If I am placing a single piece lens, so let's say I'm placing an Apthera lens, let's say that they need a 15 diopter IC8 or Apthera, depending on how much space there is, and I can get a 3.2 in the cornea. Otherwise, I'm doing a scleral tunnel in that. I think that that's going to give the patient a lot of benefit. In summary, it depends on a lot, and really it comes down to what lens power does this patient require. If they required something that I could give them an LAL or the Apthera, which is the pinhole optic, then I think that's a very reasonable thing to do. Now, if I'm doing the LAL, which is a 3-piece, or or let's say that they're not a candidate for one of those two, and I'm going to use another 3-piece like an AR40 or the AR40E, I may or may not place a CTR. It really depends on what I see. But if I get a 3-piece in the back, I'm relatively happy. If I am going to go with like a regular monofocal IOL or the IC8, which is the Apthera, then I'm probably going to place a CTR. If it's a single piece lens in the bag, then I'm going to place a CTR as well. And so for this patient in particular, it would be a long conversation, right? I mean, look, this is a challenging case, not just from a surgical standpoint, but from a what lens and what do we target standpoint. I think targeting a little myopia from the onset would be a very reasonable thing to do. Just because, not only do these RK patients tend to drift with hyperopia, but also, we know that they've got a higher chance of a more hyperopic outcome being longer axial length anyways. So I think I would target just a little bit more myopia in general, and then have a long discussion that this is going to be a complex case. Depending on whatever lens we end up using, I may or may not need to suture fixate something. And so I think for me, I would plan on probably, again, 3-piece in the bag or single piece with CTR, and then possibly a sutured segment using a CTS. And for me, it'd be some sort of Prolane, like 6.0 Prolane. And I think all of those discussions ahead of time are the most important things, because it's all about managing expectations in these patients. And that is probably what I would do. I mean, I would hope that they were a good candidate for an LAL, because it's put it in and done with a 1.8 millimeter incision, except for important point here. This patient has small pupils, so they actually wouldn't be a candidate for an LAL because their pupils are too small. So exclude everything I said about LALs, because now I remember when you said that they have poor dilation, So no, actually,
What's the pupil minimum for an
so
LAL?
really you need at least 6 mil. I mean, you can do it with 5.5, but you need 6 millimeters in the clinic, because when you're doing the light delivery device, you have to be able to see the whole optic. The whole optic, because that's what you're applying all your light treatment to activate those macromers and monomers. So in this patient in particular, I'd be deciding between the Apthera, the IC8, that pinhole optic, and probably an AR40, depending on the power, and then playing it by ear in terms of what I need to do, whether I have to suture fixate something or not. Let's say if I saw no phacodenesis whatsoever, I'd probably still put a CTR in at the end if it's a single piece, and if it looks okay, leave just a 3-piece in the bag. One other thing I wanted to mention: there are some times when I know this is a great summary, great closing here as I'm bouncing all over the place.
No, it's great.
But one other thing that people have talked about before is making larger rexes in these patients. And I don't really love that idea, because if you did have something go wrong and you wanted to try to optic capture, or you needed to do some other maneuver, it really limits your options. So I think if you can, that just goes back to staying very neutral in your nuclear disassembly in terms of stress on the zonules, is so important. So you can try to utilize that bag, because that's really where the lens is supposed to be. So that's where, you trying to maintain as much of that structure as possible, and a size that you could optic capture if you need to is I think really important.
No, that's a great point. I know some people do like to make it bigger, especially because of the contraction that they're worried about postoperatively, but that's a great point. Well, this was a heavy case, but it was a wonderful review of a lot of the things that we have to start thinking about with these complex patients. Now, shifting gears one final time to a little less eye heavy topic. Before we end the episode, I do ask all of my guests, if you could have dinner with one person from any time or place in the history of humanity, who would it be?
Wow, that is a good question. I think it would be Frank Sinatra for me.
Oh, wow.
I do. The man has style, and I really just would hope that through one dinner he could impart some of that on me.
Just rub off on me, sir.
Yeah, just a little bit.
I
Just a little
need your suave.
bit.
That's great. Well, Dr. Micheletti, thank you so much for joining me today.
Thank you, Dr. Ball. It's been my pleasure.
And thank you to our listeners. See you next time on the Pupil Pod.